All right, so Mike Stewart, it's good to have you here in Saudi Arabia, particularly in Riyadh. We're very happy to have you participating in the COMT Certificate of Orthopedic Manual Therapy course. Having somebody talking about pain on that certain course is definitely a must. So talking about pain is one of the major components of this course.
Yeah.
So we're very glad to have you here in Saudi Arabia.
Oh, I'm delighted to be here. Thanks for having me.
Mike, to start with, we'd like to know more about you. So you as a person, then we'll talk about you as a therapist.
Yeah. Me as a person, I'm probably something quite interesting about me. I'm a twin, and I have a brother and sister who are also twins. So my family has two sets of twins, which is a little unusual. And I come from a background of healthcare. My mum is a nurse, was a paediatric theatre nurse for many years. And like most people who have a mother for a nurse, you start to understand how healthcare professionals react when people aren't very well.
Yeah.
They leave you alone and tell you to get on with things. Oh yeah. I enjoy travel, which is great for me to be here in Saudi. I've always travelled a lot and enjoy exploring and adventure.
Yeah, so how's Saudi Arabia until now?
Great, really good. Colder than expected.
Yeah.
I have my jacket with me, which is good. But it's been lovely. I've been out walking the streets.
Yeah, so Mike, let's talk more about you as a physio. So have you always thought that you would be a physio since secondary school, or?
Yeah. Were you the same? Did you want to be a physio from an early age?
Well, for me, it's a little bit different because I wanted to be a biomedical engineer.
Oh,
yeah.
Okay.
But by a good chance, and I'm thankful that I'm a physio now. Yeah. But I didn't want to be a physio in the beginning.
I was one of these probably quite unusual people. I wanted to be a physio from about the age of 13, 14. So very, very early probably, but I think where that interest came from was a love of sport. So I saw physio as quite a simple, we call them in England the bag and sponge man, the person who runs on the pitch with the athlete. So I remember going for my interview to go and train to be a physiotherapist at Bradford University, and I went with all of this knowledge of anatomy and of physical education and PE, and I was really quite surprised that the people who interviewed me just wanted to know who I was. They didn't want to know all this knowledge. They just wanted to know me as a person, and it was years later I worked out why that is. It's a huge part of what we do is communication.
Yeah.
So I suspect that's what they were doing, the secret behind it.
Yeah, that's good. So so it seems like your focus, your goal were clear in the beginning, like in terms of career-wise, that you're heading to be a physio. So the other career shift is, how did you decide to deal with people with that sort of persistent pain features?
I think as soon as I went into healthcare, my first ever experience with physio was working in industry in an oil refinery. My dad worked in an oil refinery, and I spent some time in the medical centre, and there was an old physio who trained as a remedial gymnast, so as the old traditional term for physios, and there was a very new younger physio who was very scientific and evidence-based. And I started to get interested in this difference between these two approaches, these different ways of thinking and the discussions that took place. And then when I started to interact with patients in this first time, it was really interesting to see how people respond to communication, whether that's good or bad. We'll maybe explore that over the course tomorrow.
And that takes you to the decision of being looking into more those people with pain, because some of our colleague physios, they wanted to, some of them wanted to go for neurology, to be a neurophysios, pediatric physios, and some of them says, no, I want to do sports because it's like kind of easy sort of cases. These are healthy people. They want to go back to performing, thoughting that it is maybe clearer, easier than somebody who's coming with multiple issues, with comorbidities and other stuff. And choosing persistent pain sometimes is dealing with people with complex profiles.
I think that's probably why I was drawn to it. I was drawn to I like a challenge.
All right.
And I think persistent pain is very much a challenge. And I think also I've worked within sport, and I've worked within neurology and pediatrics, and I think every aspect of what we do within physiotherapy is challenging.
All right.
I think we'd be wrong to say that there is such a thing as a simple patient.
Yeah.
I think all humans have some clutter and some complexity within their presentations. And I think for me, I've always been somebody who, I like narrative, I like stories, I like listening. I'm quite a gregarious sort of character. I like meeting people and trying to get to know what makes people tick.
Yeah.
So I think those maybe are some of the key things for being a physiotherapist, whether it's persistent pain or whether it's acute pain within sport. I think I think the more I meet people around the world who are physios, the more you see some similarities in that regard. Yeah,
definitely. So today, Mike Stewart is well known around the world. That is this specialist who is talking about pain and persistent pain, and the guy who formed No Pain website, which is quite, becoming very famous very fast. So, how did that thing happen? Is it like, how did you? When is the time that you thought that I have to do this website, and people started to know you?
I think it started really. I've always been interested in education and in teaching. And if I think about, I was working with patients locally within the southeast of England, and I was becoming increasingly frustrated with the presentations that I was seeing. So I was quite upset seeing people who'd spent a lot of money not being helped, and finding that, quite sadly, healthcare was part of people's problem rather than part of people's solution. So I think, like some of the best things in life, I think the website and the courses that I run and my interest in this was born out of frustration, was born out of that desire to try and help people and empower people to start helping themselves, and that then led to trying to help other healthcare professionals develop and have some of those skills, equip them with some of those skills, which are sadly lacking, I think, often, as we know the evidence points to.
Yeah. Now, so first people get to know you outside UK or there that you practice. Was it through a podcast or?
Yeah, I think I have my good friend Jack Chew to probably thank for that. Jack is the creator of the Physio Matters podcasts. And Jack and I got together to produce a podcast, a couple of our chats, which are on his website. You can maybe make links to those for those people who haven't heard them. And then things sort of took off from there, really, with then David Pope with Physio Edge, which is where you heard of me.
That's where I know about you.
So a couple of different podcasts, and that seemed to then develop, and the amount of people who started following me on Twitter then grew, and then I ended up with this very strange situation where my wife thinks it's very funny, where people call me No Pain Mike, and they ask for autographs and to sign things, which I must say is I find quite strange sometimes. It's maybe a need within physiotherapy to seek out an expert or a guru, which I'm a strong believer in. There's not really such a thing. I think we can motivate people to try and help themselves, but we shouldn't be seen as the guru. We have that sometimes.
All right, so let's go into dive into the area of clinical stuff. So obviously this podcast is directed towards clinicians, and I'm quite sure that there are some people are going to watch this interview all over the world, but probably most of them would be from Saudi Arabia.
Yes.
Now, what would you? How would you start talking about the concept that you delivered, that you developed? Sorry, and why do you think it works in comparison to the other biopsychosocial models?
Yeah, I think the first thing to say is that there's a bit of a problem with the biopsychosocial model, or there's maybe a couple of problems.
Yeah.
One is the fact that it's biopsychosocial. A lot of the research shows that it should almost be socio-psycho-bio. The social impacts of pain are huge.
Right.
And one of the things that I've found, I've now been running courses in New Zealand and in Asia, in Singapore, now in the Middle East and in France. And I think pain is a universal human experience.
Yeah.
Culturally, there are huge differences, as I'm sure we'll discuss on the course tomorrow. But there are also lots of similarities, I think more than we give credit to sometimes.
Yeah.
I think the course really is aiming to try and give a practical application to some of the theories and some of the ideas that we have in the psychological management skills of pain, some of the sociological equipped skills that we need to need to have, and I think sometimes there's a gap between the theories that we have. We often talk about the tidy shoelaces.
Yeah.
You know, if you go into a shoe shop, you see the shoelaces in the shoe which look really neat and tidy.
Yeah.
And that's sometimes, I think, how we see some of the theories within pain, within the biopsychosocial model. My task sometimes is to help people unpick those laces and try and help people who are maybe hairdressers or car mechanics or who don't have the level of jargon that we maybe use within healthcare.
Yeah. So let's jump into how would you, in practice, how would you evaluate a patient, and before seeing the patient, do you kind of go and read about the patient in the chart like you usually do, or you said regardless whatever is happening, I'm going to hear about the whole story from the patient?
Yeah.
So how do you start?
I think the most important thing, one of the huge things that we see in the literature, is that people in pain don't feel believed. And I think it's so sad. We see this internationally. Judy Foreman is an American health journalist, and following a few years of researching and interviewing healthcare professionals and patients and researchers, she came to a conclusion. She said that there's an appalling mismatch between what people in pain need and what healthcare professionals often do or know. Yeah. And it's quite a hard conversation to have as a healthcare professional, but I think there is this gap between what people in pain often need. They need to be understood. The worst type of pain is unexplained pain. Pain is it brings fear and anger and frustration for many people. Trying to explain all of that is important. So the first thing to begin with is to listen. And I think it's important sometimes to go in blind, to not have some preconceived ideas, and have a confirmation bias as to what you think is happening in this person's life. So I often teach people, don't read the referral letter if you can. Try and just open the conversation and listen to what the person's problem is, and go from there.
We were talking about the pain as a or diving into the patient without reading the referrals and that stuff, and like going blind to the patient with the patient. Now, so can you take us through your interviewing steps, and what do you usually do as in terms of having that patient who, let's say, of having a back pain or whatever sorts of pain? Because we talked about this, that people think that chronic persistent pain is always in the back.
Yes,
and it is a little bit changing now. Right?
Yeah, I think it's important to. I think we can have persistent pain that exists anywhere, and I had somebody a while ago, a long time ago, who said to me that this patient that I have in at the moment is not somebody with chronic pain, because they were dressed like yourself. They had a suit. They just come from work, and they had a history of 25 years of ankle pain. Well, of course, that's somebody with persistent pain. Yeah. But when I asked why is this person not somebody with chronic pain or persistent pain, she said, well, it's not in a wheelchair, they're not complaining, they're not moaning, they're not. So I think sometimes we can be guilty of pigeonholing. Sometimes we think that pain education is just for people who are on crutches in a wheelchair with fibromyalgia, lots of psychosocial issues. I think pain education is for everybody, and I've been seeing that we're working within professional sport. It's great to see how professional sport is waking up to the need for understanding as the foundation of everything we do.
Great. So let me just ask you another question of why do you tend to call such a case or the term use the term of persistent pain, where the others are using central sensitization?
I think again it comes back to, if you don't work in healthcare, so if you work as a hairdresser or you work in a shop, the idea of central sensitization, it's going to go straight over your head. This makes no sense. So we call it, in our language, we'll call it central sensitization. But one of the words that often healthcare workers use is chronic, and we know that there are problems with that word. If we look at the language, the interpretations, the perceptions, Ben Darlow found a lot of this within his studies, looking at the interpretations of chronic as really bad. One participant said 2 steps from a wheelchair. That's what patients often think of as the word chronic. And I think persistent tells it like it is. Often pain will persist. Pain that's gone on for 25 years will continue to some extent, but we can turn down the volume on it, we can start to improve and reduce it and help people understand it.
Yeah, great. So going back to the interviewing skills and, that you use, so those people with persistent pain, how would you go, if you can take us through the whole interview skills that you or the steps that you use?
I think the first most important thing, the thing that I often try to get across to my colleagues and to healthcare workers, is the need to maybe have less tick box type approach. So we call it tick boxology. This idea that somebody comes to see you, and if you think about it from a human perspective, pain is a really complex, distressing phenomena. So people turn up to come and see us with all of this distress and all of this chaos in their lives that's been invading their lives. And the first thing that we do is we get a bit of paper, or we get a TV screen or a computer screen in front of us. We don't listen to the human. If this was a conversation taking place between you and your friend was in this amount of distress, you wouldn't start writing things down. So I think I was trained as a Maitland practitioner. I have a very, very structured subjective examination style. But I think it's important to let the patient take control sometimes in that first session. Listen to what they want, listen to the story that they have.
And is there any particular advice, like do you ask about a few things such as lack of sleep, people who lost motivation on doing stuff that they used to enjoy, or it's just a sort of a regular interview like any physiotherapy interview?
I think there has to be, we know, lots of open questions, a Socratic style. So Socratic meaning a guided discovery approach. Socratic questioning comes from Socrates, the great Greek philosopher. Socrates always said, to find yourself, you have to think for yourself. So I think it's really important for us as educators to try and make sure that our patients are answering their own questions. We're not telling them, we're guiding and we're signposting. So I think we have to maybe talk about all of the different ways that pain impacts on people's lives. A good way to do that maybe is to write on a piece of paper problems in the middle, and then ask the patient to come up with all the things that are stopping or preventing them from living a life that's fulfilling and joyful. I had an example a while ago. I had a patient who we did just this with. We said, what are your problems? Can you write them down for me? Can you tell me what they are? And he wrote all of the usual things that you would expect. So lack of sleep, inability to earn money, inability to fulfill his role as a father, to play with his children. But one of them that he said was he didn't feel able to smile. Well, I was interested. I thought, is this him saying that he's depressed? maybe. So we spoke about it, and it wasn't that at all. It was the fact that he had a tooth that had decayed. And because he had a tooth that didn't look very nice, he couldn't smile, and that made him feel miserable, which then impacted on his pain.
Oh, yeah.
So I think that's a really nice example of how sometimes the biggest problem that somebody presents with is not what you expect. It's trying to bridge that gap between the problems that they have and what you think is happening.
And I would assume that those things would be picked up during the first interview or through discussing those sort of experience, if the terminology would help, the experience of whatever the patient is having, and picking up those information, put them together, and see if those make sense to the whole picture.
Yes, to making a bigger picture of things, and I think often, as educators, we educate people every day. Yeah. I often one of the big things that I do with No Pain is to try and help clinicians have educational skills, because I think this is something that's lacking. I went to a conference a while ago in Birmingham in the UK, and we had 400 people in the room, and I said to them, could you put your hands up if you educate your patients on a daily basis? Every hand in the room went up. I then said, okay, could you put your hand up again if you understand education, who's qualified as a teacher? And 2 or 3 hands out of 400 went up. So there's this huge gap, I think, and I think we have to try and understand how people learn, and there's a whole range of ways that we can do that, and how maybe sometimes we have to talk less, listen more, get people to discover what's happening in their own words, not a formulaic way that we give them information.
Yeah, and do you think that the setup of the interviewing desk or area has to be designed in a way to break the barriers, or let's say break the ice between the practitioner patients, regular practice? Like we've seen here in some of our clinics that there are areas where therapists and patients, they sit on one round table, or there are some areas where you sit on a desk and the patient is on the next side of the desk.
It's a huge problem, and I think if you look at the evidence for all of these non-verbal metaphors, because this is what we're really talking about. Metaphors aren't always verbal. Sometimes they're physical. So we know this when we shake hands with somebody. We interpret who that person is. We judge that person through their handshake, whether it's a hard handshake or soft. Or we also judge somebody based on where we're sitting. So you and me at the moment are sort of sat in quite a collaborative, nice informal position. If we were to move our chairs directly opposite each other, which is where often clinicians and patients are, then this is a combative stance. This is something that we know from Hargey's research. This is you and I are not in this together. We're miles apart. And the same is true for if you're a clinician who you maybe sit on the treatment couch on the plinth, and you find that you're 5 or 6 inches taller or higher than your patient. What's that saying? Without saying a word, we're saying a lot there. I'm up here, I'm in charge, you're down here. So there's a lot that's being said without speaking. And I think it's important to understand the impact that the environment has on the consultation process.
All right. So if you would weigh the importance of the process that you take with the patient, which is usually interview, then physical exam, and then giving the diagnosis or the assessment that you would come with. So how much you would weigh the interview process to the whole process of the session, let's say.
In session 1?
Yeah.
I think the first thing to point out is you can never expect to get the full story in session 1. I can think of, I can count patients on one hand who you think in that first session I've got all the information I need. So I don't think we should assume and be naive and think that we got everything. Often I discover things about people in session 3, session 4, session 5. So I think the important point to make is during that build-up of rapport, if you don't feel like you've established a rapport and you don't feel like you're improving and the patient's getting better within maybe 2 or 3 sessions, we have to stop. We have to think, why is this not changing?
Yeah.
What's the barrier here, or what are the barriers?
Yeah. We've been through the interview and how what's the importance of it, and the importance of gathering information in that sort of process. You don't think that there are an important elements that you have to cover during the interview, or it's just a matter of gathering and taking that sort of holistic sort of information about the patient? Or you think that there is an area that you shouldn't miss, like about the type of pain, red flags?
Yeah.
So do you still, because you say that we should go in blind, so do you start like from the beginning?
Yeah.
Or there are areas that you think that it should be covered in order to have a full interviewing process?
It has to be fluid. It has to be there has to be a structure.
Yeah.
So I think if I look, particularly as a Maitland trained practitioner, you have to have the structure that works for you, the framework that sits for you.
Yeah.
But you have to step away from the person who's in control of that structure all the time. You have to be prepared, and it's quite a skill to develop. And I think this is why I know with working with younger clinicians and undergraduates, it can be quite scary giving control to the patient. But still in here, there's that structure.
Yeah.
So I still know in that first session that I've got to talk about red flags, and that I have to consider where the pain is, and the bio within the biopsychosocial.
Yeah.
I have to think about structure. I have to think about anatomy. I have to think about biomechanics. We can't throw those out the window.
Good. So you don't disregard those and say that I'm going to go about pain experience and all of that.
No, how can you? I think if you do, I had an example of this a while ago where I was referred a patient from a doctor who the doctor said, I think this lady is just anxious and just worried, and there was something serious happening. She had cancer, and there was all of these signs and these symptoms had been misinterpreted as worry.
Yeah.
And actually there was, red flags galore here. And I think Louis Gifford always spoke about in parallel reasoning, about how we have to have train track thinking. So there has to be this train track, which is thinking biomedically about structure and biomechanics and anatomy.
Yeah.
But equally, there has to be this, which is thinking about the human and all the clutter that comes with pain.
All right. So if we move on to the treatment aspect, and talking about those treatment options that you go through or explain with the patient. First of all, do you, after taking those sorts of information about your patient, and you've mentioned that it might take you about 4 or 5 sessions in order to fully understand the concept or the full story about the patients, because some of those patients they tend to hide some information. They don't feel secure to delivering the full facts about their side of the story.
Yeah.
So after gathering those kind of information, do you kind of go through sort of structured treatment, like a sort of algorithm? If it is this, then you do that. If it's this, then I will do this. Or it differs?
It differs all the time, and I think it must differ. I think if we look at the unique individual needs that people come to see us with, then we have to see each experience as being tailored, as being different. But at the same time, of course, there is some pattern recognition.
Yeah.
There are things, we know this, that the longer you've been doing this job, the more you start to recognize certain patterns and pictures, and as you say, algorithms. So it's a meshing of those two things. I think you have to have both of those. But we can't see this as being formulaic, as being a recipe.
Yeah.
I was asked a question. I always, at the start of a course, I give people a wish list. So I ask them, as the delegates, to tell me what is it? What's their aim? What's their wish? What do they want to get from this course? And interestingly, I had somebody, a physio, who said to me, I want to be able to tell what percentage of somebody's problem is bio, what percentage is psycho, and what percentage is social. And you can see the problem with this. It's
it's so much into
confining things into boxes. And I think in reality, human beings don't look like they might appear in a textbook. Far more complex, and we have to be far more fluid to react to those situations.
But how would you answer those people who believe that there are some great scientists and researchers who has come up with algorithms about dealing with people with central sensitization, or people with motor control issues, or people with persistent pain, and they say that you should go into a series of steps, and they are either of this or either of that, or it's something else. But it's a sort of process of yes or no. How would you fit into this? Do you agree or disagree with this sort of way of thinking?
I'm going to be controversial here. I neither agree nor disagree. I think it's important within what we do to recognise that there isn't one truth. There isn't one particular answer that answers all questions. And I think it's important. In my practice, I use outcome measures, and I go through and I try and eliminate certain things as I'm going through the process. But at that same time, this other side of my thinking has to be thinking about the cluttered complexities that we're seeing. So this is again marrying up the qualitative and the quantitative within every consultation. So
if I understand you correctly, that would say that it's good to use some of the quantitative data in order to rule out a few things. And then as some of the literature suggests, that 85% of those people would come with chronic non-specific issues, and here where you have to talk about the qualitative issues with the patients.
I think we can never really move, we shouldn't really ever move too far towards one extreme on a spectrum. If we start to think that everything is all psychosocial and everything can be answered with tick boxes and forms and paperwork, then this is not correct. Equally, if we think that everything can be answered with a discussion and a narrative approach, that's not correct either. I think there has to be a degree of balance always within what we do.
So, going back to the treatment, would you use a certain technique, like a certain set of exercises, or I come to know that you are trained even in cognitive behavior therapy, where you've done about a year of postgraduate studies in there. So do you do like sort of CBT, or exercise, or ACT therapy, or a bit of all of these?
A bit of everything. And I think one of the things that we explore on the course is how to merge all of these things, because in reality they don't sit neatly on a piece of paper. So CBT and ACT and graded exposure and manual therapy, all of these different things that we have in our toolbox, they merge together, and we have to try and discover practical ways that we can apply within practice, that where we're maybe using psychological techniques, but we're trying not to use the word psychological techniques. I think the trick sometimes is to try and help people join the dots. So as they're not just thinking their pain is coming from tissue, that it does involve them as a human, and a human experience, an embodied experience. But at the same time, we're not getting them to think that they're mad, or that this is a psychological thing. This is a huge challenge that clinicians are facing, is how do we talk about the biopsychosocial whilst engaging people rather than losing people?
All right. So I see that you focus a lot into the clinician-patient communication, and establishing that bond and trust. But could you briefly or give us an overview of whom do you use CPT with, ACT therapy with, and the sort of manual therapy if you do, or you think it's impossible to give a certain profile to such sorts of patients?
I think the nature of, if we look at maybe motivational interviewing, the nature of motivational interviewing is about finding somebody's desire and trying to elicit behavioural change and to see how psychologically flexible is this person, which is the same as ACT and maybe similar to CBT. So I always think within the first session or 2 or 3, I'm really trying to work out how ready is this person to commit to self-management, to doing things themselves, and how flexible are they? A lot of the research, a lot of the literature shows the important thing for a lot of people with pain is the ability to be psychologically flexible. Now there's we can't talk about that. If you and I were in a consultation, if I said to you I need to establish how psychologically flexible you are, you're going to walk out the door probably, or punch me, or most people are not going to be happy with that idea. So as an educator, maybe we have to be a bit more creative. We've got to find other ways of looking at this. So I'll give you a practical example. Do you ever see patients who they're constantly fighting and struggling and battling to find a fix and a cure?
Yeah.
Maybe they've seen 6 chiropractors and 12 osteopaths and 142 physiotherapy sessions. So you've got a couple of options really. You've got a traditional didactic approach. So I could sit and tell you that this is not good. I might point a finger occasionally and say you should take a different approach. I think you need to stop trying so hard and fighting. What are you likely to do in that situation?
You would lay back and say, as a patient you're talking, as I would say that this is so tough.
I might not see you again.
Yeah.
You might go and attend somebody else, and that's not a good way of enhancing a bond and making somebody feel believed and wanted. So Matisse, the artist, says creativity takes courage. And I think as clinicians, we have to be courageous to get a bit creative sometimes. We have to use experiential learning.
Yeah.
Do you ever see one of these?
No. Yeah.
Okay, we'll try something. So rather than tell you that you're trying too hard and you're battling and fighting, we can use an experiential learning style. So this is learning through feeling, which is what we do with manual therapy. Yeah. Manual therapy is all about learning through touch.
Yeah.
We discover through touch. We teach people how their body reacts through touch. So I can teach you another way. Could I get you to put your fingers, these fingers, put them quite far in, enough to get a bit stuck. I want you to get a bit stuck inside here.
All right, so both of my fingers, is that right?
Yeah, both fingers. I think the important thing to do as well, if you were my patient, I would always say to you, do you mind if we try something? Don't just go in and say, do this for me.
Yeah.
Always ask that question, knock on their cognitive door.
Yeah.
Is this okay? Do you mind if we try something new? If they say no, then obviously no, don't do it. But often I've never had a no. If you ask, people will be curious maybe. Yeah. Try this for me.
Alright, so from both sides.
Get quite stuck. Now I want you to try and see if you can escape this. Don't touch it with your thumbs or anything else. Work out how you're going to get out of this trap. Yeah. What's your instinct? What do you do first?
I'm pulling both of my fingers away.
So to try and escape the trap you're pulling, what's happening?
It sticks.
Is it working?
No.
Is it a good option? Is it a good thing to do?
I think it's a bad option now.
The harder you pull, what happens?
The harder I pull, the harder it sticks.
The harder you fight, the more you get stuck?
Yeah.
What's the answer? Try and work out how you're going to get out. I'm not going to tell you, I want you to work it out. Remember? To find yourself, think for yourself, Socrates says. This is about guiding you to discovery.
So I don't have to use the other.
No. That's it. You get there. You'll get there.
Yeah.
Oh, there you are. You're getting there.
Yeah.
Got it. Well done.
Yeah.
You're out the trap.
Yeah.
What did you learn? What did you discover? What did that experiment teach you?
Maybe it's not about the force.
the fight,
the
struggle.
fight, the struggle. It's just about how do you find your exit, and being more of easy way of there are easy way of doing things rather than difficult way of doing it.
Now, I've not had to tell you. I'm not sitting there as the teacher going, this is what you must do. You must do these things. You've just figured that out for yourself.
Yeah.
And I think this is all about, what did you have to do to get out?
I just had to push and turn.
Yeah. So this is a Chinese finger trap. The Chinese love metaphors, and the metaphor here is to understand something, you have to go into it. So pain education is all about going in. It's all about exploring the experience. I had a patient a while ago who said to me, he wasn't engaged in pain education at all. He came to one of our groups and he was completely disengaged. And we did this, and he said, okay, maybe I've got to go into it. Maybe I have to open the box and explore it. And rather than, like we always say, that doing the ostrich. An ostrich buries their head in the sand and just tries to ignore everything. So this is a nice psychological technique. This is ACT. It's about acceptance. It's about behavioural change and flexibility. But not once did I use the term acceptance or psychology. Or
definitely.
It's trying to discover facilitational ways of guiding people.
And you've mentioned some examples about asking patients to draw their pain and how would that help.
Yeah.
So is it another way of letting the patient find the solution? So you only guide, and then ask let the patient find their way of the treatment. That is not something impossible.
Pain is a really difficult thing to try and describe. As clinicians, the first thing that we do when we see people in pain is we'll say, "How's your pain? What's it like?"
Yeah.
Most people go, "Well, I don't know, it's pain." Most people don't have the words to describe their pain.
Yeah.
So we force them into our words. We have recipes of our words.
Yeah.
The McGill Pain Questionnaire is one example. And those words that we use are often to do with fight and battle, stabbing, shooting, burning, lanciating, throbbing.
Yeah.
Which, it's not the true depiction of that person's experience. It's the words that we've given them.
Yeah.
So drawing can be a great way to try and go beyond words and try and help people make sense of their experience.
Yeah.
And I think it gives us a visual narrative space. We have this, if you were to draw your pain for me, we now have something we can discuss.
Yeah.
So you have your drawing, let's say it was a drawing of a lightning bolt or whatever it is. We've now have this thing that we can now talk about. We can discuss this.
And so you turn that something which is in my perception into a visual, tangible thing.
Yeah, exactly.
And that we can work into changing, like maybe why it is red. And then we go through this discussion.
Yeah, I think one of the most important things for us to do as clinicians is to elicit change talk and elicit empathy through dialogue, through discussion. And we have to discover maybe creative ways of trying to elicit those things. So drawing is one of them. I had a story in France from somebody who came to one of the courses who said that she'd been trying to work with this lady for a long time and trying to make sense of what was causing her pain, and she couldn't get any answers. And then after doing the course and starting to try and learn about drawing pain, her patient drew a picture of a man, and it was her husband. And out of that came all of these discussions about this problem she was having within her marriage and all the stress that came with that and the anxieties. So you can open a can of worms, you can open this box of problems, but I think that's sometimes important to elicit those things too.
Yeah. So Mike, just to conclude, if you can list the most important 5 things that you would give as a tip for the physios all over the world, and for physios practicing in Saudi Arabia in particular, about dealing with those people with resistant pain. What would you choose?
Okay, I think the first thing is to be interested in the topic, because if you're not interested, your patients are not going to be interested. One of the most important things that we've got to do is to gain somebody's curiosity, somebody's interest, and if you're not interested in what's happening, you've lost them already. So it's trying to be curious and almost an explorer of ideas, which is things like this.
Yeah.
I think the other thing is that keep it simple. Less is more. I see lots of examples of patients who come to see me and they've been given 15 exercises in the last 5 minutes of a consultation. They've just been thrown a piece of paper and do one thing really well rather than sort of 9 things not very well. I think that's a really important thing to do. And I think also we have to rethink what pain is. Pain is not this simple experience that's coming from a piece of damaged tissue, that it is something far more complex, that it is based in threat, it's based on your perception of threat. So I think as soon as you reconceptualize pain as a threat experience, you start to understand that this is a threat machine. Every word that comes out of here contains the possibility of threat. The things that you put up on your walls contain lots of threats. People in pain are seeking threat information. They're looking for things to confirm their beliefs that their back pain is cancer, so don't give them those opportunities. Yeah.
All right. So at the end of this interesting talk, Mike, thank you very much for being part of Training for You courses. Thank you for being here in Saudi Arabia. It was a pleasure meeting you.
Thanks for having me. It's been a pleasure. Thank you very much.
Bye-bye.
Bye.